I did.
You recorded, okay.
Yes.
All right, I'm just introducing Paul Fager, who's going to speak to people. Thanks, it's wonderful to be back at Brain Day. I actually organized the first one 16 years ago, and I was inspired by an event I read about called Montreal Pain Day. And I thought, well, Montreal can have a pain day, Waterloo can have a brain day. And I'm delighted that it's continued by Beth and Chris Elias Smith and Britt Anderson. I also think it's really nice that the format is continued. So we've still got the same basic structure with neuroscience and psychology, computer modeling, and philosophy. Philosophy is actually a really important part of brain science, not because it's dealing in exactly the same empirical or theoretical way, but because philosophy deals with really important general questions about the nature of knowledge and reality and morality. So philosophy has always been an important part of it, and with respect to the brain, it's very interesting, wonderful that we've got a speaker today who works in philosophy of psychiatry. But most of the talks at Brain Day have been concerned with how the brain works when it's working well. But of course, the brain doesn't always work well. Sometimes it works badly. People have mental illnesses. And psychiatry is the branch of medicine concerned with those sorts of thinking, those sorts of illnesses. Now, Serife came from Turkey to study philosophy at York University in Toronto. Ever since then, she's done really wonderful work in philosophy of psychiatry and establishing that field. Aside from great work on himself that we're going to hear about today, she's also done really interesting work on the ethics of using chatbots in psychotherapy. So we're really lucky today to have Serife Tekin to talk to us about this also in psychiatry.
Thank you so much, Paul, for that wonderful introduction. Thanks. Thank you for having me. It's always so great to come back to Canada. I had one day to spend in Toronto, and I took all Toronto in me, tried to absorb it, pack it with me to go back to Texas. So today I will be talking about substance use disorders, primarily opioid use disorders, and I will be giving a lot of different kinds of examples to illustrate some of my concerns in the way contemporary clinical approaches are shaped in psychiatry. I want to start by pointing out that there's a crisis in both mental health and in mental health research at the moment. So when we look at the kind of statistics to the mental health side of things, the number of individuals who encounter some kind of mental disorders throughout their lives in the context of North America is about 1 to 5. So one each 5 of us encounters some kind of mental disorder throughout our lives. And right now is a very, very interesting time in psychiatry and research psychiatry and clinical psychiatry in that as the former director of the National Institute of Mental Health, which is one of the largest funding agencies in the United States that funds mental health research, he calls this revolution stalled. And the revolution he's referring to is drug revolution. When we look at psychotropic medications, we are no longer, or I should not say we, pharmacological companies are no longer producing new psychotropic drugs because they have realized that there are limitations to the effectiveness of drugs. The current existing drugs for a variety of mental disorders are effective for a group of people, but they also have a lot of side effects that increasingly patients are reluctant to take them and clinicians are reluctant to prescribe them. And drug production is no longer a profitable, profit-making in kind of area of enterprise for the pharmacological companies, and they're leaving the business. So it will be interesting to see how that unfolds. With the pandemic, everything got worse in the sense that we had a higher prevalence of mental health-related issues due to a variety of kind of side effects of the pandemic. And to this, which is not what I'm going to talk about today, there's an increased enthusiasm about artificially intelligent technologies providing the kinds of interventions that perhaps biological psychiatry have not been able to provide. So there's a lot of enthusiasm right now. And again, the former director of the National Institute of Mental Health, Thomas Insel, who had been a big promoter of neuroscience in kind of helping us fathom mental disorders and develop effective interventions, have declared publicly that he has been quite disappointed by neuroscience, and he himself moved to kind of working in the context of artificial intelligence technologies to develop mental health interventions. So one of the ways in which that we should understand this crisis is, or we could understand this crisis as a philosopher, is by looking at kind of knowledge generation processes in psychiatry, because we have multiple areas of inquiry working together so that we can get to that moment with the patient who is suffering from a mental disorder and provide mechanisms to help them. So when we look at kind of knowledge generation process, Miriam Solomon, a philosopher of medicine, kind of labeled this process in medical knowledge as epistemic rituals, and we can kind of easily apply it to the context of psychiatry. And us philosophers of science think a lot about what science is, what science does. Today, I will be thinking about psychiatry as a primarily intervention-oriented science, meaning the goal is not just to kind of understand the brain or understand the self, but also to develop mechanisms and intervention methods that will improve the mental health status of the individual that we are interacting. So when we look at this kind of sources of information or sources of knowledge in psychiatric knowledge production process, we have what I can kind of outline like 3 different set of practices. So first line of practice is scientific practices. This includes all psychotropic drug development or kind of neuroscientific research and so on and so forth, clinical trials and so on and so forth. And for instance, the Diagnostic and Statistical Manual of Mental Disorders that I'm going to be talking about today is a guide developed to provide a taxonomy of mental disorders. It's primarily a scientific document, but it's intended to be used in different contexts, such as education of medical students, psychiatric diagnosis, development of treatment plans, and so on and so forth. So it has a lot of power. Another kind of set of source of knowledge in psychiatry comes from clinical practices. So not all clinicians or psychiatrists are academic researchers. A lot of them just primarily work with patients, and using that kind of process, some of them publish case studies that gives us information about one particular patient, but we can later generalize it and apply it to different patients and different populations. Similarly, various clinical trials can be examples of these clinical practices. A third source of knowledge about mental disorders comes from patients themselves. They report on their experiences to their clinicians, to their friends. They sometimes write memoirs or blog entries or Reddit posts, including or make TikToks. I have a lot of students who live in the TikTok world, so I'm kind of getting bombarded by all these different first-person testimonies coming from that circle that provide kind of this first-person lived experience reporting of mental disorders. Interestingly, and that's kind of the issue that I'm going to take today, in psychiatry, in scientific psychiatry, there has been a lot of reliance on scientific practices and clinical practices as reliable information generating processes, but self-reports have been undermined or neglected. I kind of frame this as like the neglect of the self in psychiatry. So the plan for today is I'm going to exemplify what I mean by psychiatry's neglect of the self by talking about this phenomenon that I called psychiatry's twin failures. On the one hand, there's an overall neglect and undermining of subjectivity that is involved in mental disorders. On the other hand, a neglect of self-reports or first-person reports of patients, especially in the scientific context. And these are related, but they're not the same thing. I'll talk about that by using primarily opioid use disorders as my examples. And the kind of another case, my focus will be primarily the DSM-oriented psychiatry, but we can maybe generalize this kind of framework in other contexts as well that I'm happy to go in the question period. And I'm going to then tackle this kind of, try to understand why there's so much resistance in thinking about subjectivity and self-reports in the context of psychiatry. And I'm going to trace that to this fear that somehow patient inclusion or engaging with subjectivity will spoil psychiatry's goals of becoming an objective scientific inquiry. And I will show that that's not a legitimate worry at this point, especially if we update on how we think about science, especially how we think about a science like psychiatry, which is primarily targeting effective clinical interventions. And I will develop an alternative framework that I call participatory interactive objectivity, in which patient reports and patient engagement is an intrinsic central aspect of scientific development process. And I will conclude with some objections. So let's look at psychiatry's twin failures. So the DSM-based scientific psychiatry, like the manual that provides criteria for mental disorders, and that is used in a variety of contexts of diagnosis, treatment, and so on and so forth, focuses primarily on the behavioral symptoms and signs of mental disorders to illustrate, to provide an accurate criteria of what mental disorders are. So, and in these kind of more behavior-oriented symptom and sign description, such as insomnia, right? An experience that can be reported by first person, but also can be validated by observers. Your partner can see that you are having difficulty sleeping, for instance. In this kind of framework, there has been like a lot of kind of disengagement with kind of the actual subjective experience of the individual. So, and in that sense, because the DSM is a guide for developing research paradigms and understanding mental disorders, this kind of neglect has been carried over. So there is this assumption, there is this basically subjective experience as explicit research and treatment target has been marginalized. When we dig deeper, one of the reasons for this marginalization is that there is this assumption that the subjective dimensions of mental disorders will be addressed if the physiological dimensions are addressed. So if we can, I don't know, somehow figure out the mechanism of insomnia, we don't have to directly talk about insomnia, but if we figure out the underlying mechanism and target it with certain interventions like medications, that will go away. So unfortunately, recent work in neuroscience and clinical neuroscience has shown us that treatments using symptoms and signs as markers of psychopathology that in a way that sideline subjective experience have not been as effective as anticipated. So the other kind of dimension of neglecting the self or subjectivity can be seen when we look at the knowledge generation process in scientific psychiatry. So patients self-reports, these first-person reports of experiences, as I consider things that could approximate us to subjective experience, have also been marginalized. Patients were never included systematically as subjects of research. Of course, when you run a clinical trial, you have subjects, research subjects. But what I mean here is that they've never been considered as participants of research who generate research programs. So, and this is problematic, especially when we think about the goal of psychiatry to develop effective clinical interventions that will improve that patient's experiences. And in different areas of science, like perception, which I will talk about a little later, kind of trusting or basing scientific research on self-reports is like the fundamental scientific methodology. Yet in psychiatry and in clinical sciences, there has been this kind of hesitation to engage with those self-reports. But when we look at actual self-reports, we can come across information and knowledge that gives us kind of signals for how we might want to intervene on mental disorders. So in some sense, I want to think about self-reports as getting us to clinically relevant phenomena about mental disorders. So what do we learn from self-reports? Well, basically, one of the things that we learn from self-reports is what I call orientational challenges involved in mental disorders. This is basically a particular form of mental disorder affecting and changing the way that you are yourself in a given day. You might have difficulty getting up in the morning, you might have trouble sleeping, or you might have extreme heightened anxiety in certain situations. This is basically how mental disorder kind of shapes the structure of your orientation in the world. Another thing that we learn about self-reports that, again, in psychiatry, in scientific psychiatry, has really not been engaged with is what I call hyper-narratives. So we are not just brains in a skull. We're intrinsically social. We live in racist or sexist societies or environments, and all of these things end up affecting the way in which we might encounter mental disorders. And in some contexts, they emerge hand in hand, right? So it's important for us to understand these dimensions of an individual's experience to help them in the clinical context, yet these kinds of hyper-narratives have not been traditionally part of scientific frameworks in psychiatry. We also learn a lot about how a particular diagnosis might influence an individual and the ways in which that they might be treated, what kind of clinical treatments they might receive, and what works, what doesn't work, and so on and so forth. Another dimension, this is something that I've worked on early on in my career with the influence of Canadian philosopher Ian Hacking, is what he calls looping effects, what I call the reflective impact of psychiatric diagnosis. If your experience is suddenly classified and described and represented as depression, you might develop a different relationship with yourself. You might think that you will never be happy or something like that, even though that can be scientifically ungrounded. And finally, we learn about, another thing that we learn, especially from these first-person accounts, is the way in which people might cope with their experiences and how they overcome. And a lot of the kind of more memoir length of these, first-person reports have this kind of like narrative hook where, our hero finds something that works for them. And often that something is something like having meaningful relationships or meaningful work environment and so on and so forth. Finally, I think another thing that we see in these self-reports that is not necessarily part of the kind of clinical framework in thinking about mental disorders is this idea of flourishing, learning to kind of come to terms with the challenges that one might encounter and live a meaningful life. And again, because clinical psychiatry is primarily focused on fixing the dysfunction, it's sometimes hard to see whether or not one could flourish in that framework without having to fix that dysfunction. So, and these are the kinds of things that we can learn from self-reports. I'm going to give an example of how turning to self-reports might generate a change in the way that we look at opioid use disorders in ways that traditional psychiatric frameworks do not. So I'm going to give opioid use disorder and the overdose epidemic as my example. So I don't have to repeat the statistics. Opioid use disorder is an increasingly concerning mental disorder prevalent in both United States and Canada. And if we kind of look at the way in which opioids end up causing addiction or substance use disorders, is that opioids are these natural or synthetic chemicals. They interact with our opioid receptors and reduce pain. And unlike other substances, the speed in which one might develop kind of abusive behavior is very fast. One might develop physical dependence in 4 to 8 weeks. And abrupt stopping leads to very severe withdrawal symptoms like generalized pain, chills, cramps, vomiting. These withdrawal symptoms are so harsh that kind of trying to abstain from opioid use usually doesn't work. So, and in North America, in Canada and the United States, abstinence-based programs are dominant, but they have poor outcomes because it's hard to stick with this kind of full abstinence form of intervention. There is more success with what's called maintenance therapy, where patients receive injectable opioids under supervised conditions. So maintenance therapy comes in a continuum. In a lot of parts of the world, especially Europe, the kind of opioid that is used in that maintenance therapy framework is variant. In the kind of middle spectrum, there is intervention using methadone. But at the kind of, when the methadone-assisted management therapy doesn't work, there is room for heroin-assisted treatment. So heroin-assisted treatment basically is a form of treatment where patients receive long-term treatment refractory with OUD, treatment refractory or opioid use disorders, receive prescribed injectable heroin. So heroin-assisted treatment is an effective form of treatment that is widely used in Europe. So much so that in countries like Denmark, Germany, Luxembourg, Netherlands, and the United Kingdom, it's not allowed to run more clinical trials on the effectiveness of heroin-assisted treatment because it's considered an established form of treatment. Yet, because heroin use is illegal in Canada and the United States, we cannot use this form of treatment that actually has a lot of promise to helping people. In the DSM-5, for instance, there is actually, I was pleasantly surprised when I saw this, there is a section on maintenance therapy. It does recognize it as a form of treatment, but the kind of maintenance that you can, the kind of drug that you can use in maintenance therapy is limited to methadone. So they do not allow or consider heroin as a possible way of intervening on opioid use disorders. So I have another paper where kind of we trace, it's a co-authored paper with Daniel Still, where we trace the origins of this kind of, I guess, stigma against heroin-assisted treatment as different understandings of treatment and intervention in psychiatry that I'm happy to send along. But in a way that it kind of relates to the talk today, because Canada is a lot better in terms of a lot of things than the United States, and especially in British Columbia, the province had allowed some clinical trials that use heroin-assisted treatment as a form of intervention. This is a study called Salome, and it's basically a study to assess longer-term opioid medication effectiveness. This was run in 2017 for a few years in a downtown clinic in Vancouver, where patients received injectable heroin as a form of intervention. It wasn't like they were just kind of they were getting higher doses of heroin. Rather, it was supervised. While the patients were in the clinic, they were receiving other forms of medical care. They were connecting to other people who are sharing the same experiences. And when we look at the self-reports of the participants of this study, results are, the insights are really, really overwhelming. They talk about how they were able to get off the streets. They stopped stealing to find illegal drugs. This kind of regular visits to the downtown clinic allowed them to hold jobs and have relationships. They were no longer homeless. So the study was a tremendous success that illustrates the kind of effectiveness of these kinds of interventions by looking at self-reports. And also what's really interesting is the clinical study, of course, the clinical trial stopped. They have to come to an end. And after that, patients they no longer had access to assisted injectable heroin for their treatment. And they formed this kind of research/activist group that kind of brought together the group of individuals. They were all kind of, researchers themselves. They have become researchers in the context of this kind of activism and knowledge generation process. And they have actually published papers on, their life prior to this trial and after this trial. What was it that, how it was helpful, and they kind of try to now advocate and lobby the provincial government and the Canadian government for these kinds of treatments to be allowed. So this is an example of the kinds of things that I think if we turn to patients as sources of knowledge generation, that we can kind of learn from them, from their experiences, in a way that supplements scientific and clinical research on psychiatry. And especially given that our goals are to develop interventions, but they have not been taken seriously in a systematic way. So I want to kind of summarize like what we've done so far. So what I try to say is self-reports and engagement with subjectivity have been kind of less central for scientific research in psychiatry, but this kind of neglect and oversight has negative epistemic and ethical consequences. Epistemic because we are not learning what we could be learning about those individuals' experiences. Ethical because we have responsibility, especially in the context of medicine, to do the best, to provide the best treatment, effective treatment for the patients. We might be withholding some forms of effective treatments for the patients because we are not listening to their experiences. So one might say, and actually the creators of the Diagnostic and Statistical Manual of Mental Disorders do say this, there's this kind of resistance to engage with subjective dimensions of mental disorders, and similarly with self-reports of individuals with mental disorders, primarily because there is this kind of assumption that patient inclusion or engagement with subjectivity might impede objectivity. This is in fact what happened. So in 2013, the DSM-5 was being published. So one kind of step back. So the Diagnostic and Statistical Manual of Mental Disorders is like this framework to make sense of mental disorders, classify them. And the idea from its inception, back dating 1952, was as science progresses, as we know more about mental disorders, our criteria for diagnosis or our kind of framework is also going to be subject to change. So DSM pitches itself as a primarily scientific document in that sense. So the more we learn, the more science progresses, the better we will get at individuating mental disorders. So in that sense, that's why the DSMs are regularly revised. We are now in 5.1 edition. So there were DSM 1, 2, 3, 4 in Roman numbers, and now we switched to numericals, DSM-5, and the DSM-5.1 was just released last year. So right prior to the publication of the DSM-5, there was actually a lot of advocacy and interest and push for including patients themselves in this diagnostic kind of development process. Right now, the way the American Psychiatric Association works is that there's the APA, and they have different working groups, and those working groups are composed of clinical psychiatrists, researchers, and they each focus on like a particular mental disorder, and all of that is then harmonized in the kind of DSM-5 through various structures. Like it's a very political process. And there was this push to include patients also in that cycle. And the kind of like this push came from patients themselves, psychiatrists, and actually also philosophers of psychiatry. And I was at that meeting at the American Psychiatric Association prior to the release in 2013. There was a lot of protests going on outside where patients were critical of the American Psychiatric Association, not listening to them and not listening to their experiences. And a lot of these arguments kind of had a more social political justification for the inclusion of patients in the development of the DSM. Basically, democracy requires all stakeholders to be part of decision-making process. Patients and even families are stakeholders, so they should be part of this decision-making process. There wasn't a lot of emphasis on epistemic reasons on why actually providing first-person information and contribution by patients might be a good kind of an aspect of scientific knowledge generation. But and the DSM-5 task force, interestingly, actually resisted the inclusion of patients by citing science. So they said, okay, actually, of course, like everybody should be involved in developing this like gigantic document that has a lot of power. How about we open the DSM-5 to general public commentary? So there's a difference between asking patients and people who are encountering mental disorders directly for input versus asking it to the general public, right? In the first case, we might say, well, individuals with mental disorders have situated knowledge. What they might contribute is very, very important, more so than a member of a general public who never encountered mental disorders. But they didn't want to do that primarily because they said, we are interested in creating a scientific criteria for mental disorders, but including patients will kind of impede that goal. So this is what they said. By definition, subjectivity is variable from person to person therefore making it impossible to develop objective criteria that would apply to every disorder. Further, it raises the question of whose subjective experience will serve as a template by which criteria would be developed. So this is a fair concern, but at the same time, in kind of raising challenges on the grounds of subjectivity, is also illustrating that the DSM's conception of science may not be as up to date in the way that we currently think about science. I'm going to explain this. So in this statement and in a number of other documents, DSM kind of highlights a series of assumptions about what objectivity is and how we should do science. And a lot of these assumptions are coming from a particular view of science where science is objectivity is considered to be an outcome of scientific inquiry. We all do research and then we arrive truth. We arrive at true knowledge. That's also the objective knowledge. And this was a dominant framework of thinking of the way in which we thought about science in kind of a historical moment in time during logical positivism, where the ideal model of science was taken as physics or chemistry, where it was possible to, we can't really say that even in the examples of those science, but we could arrive at this like one form of knowledge that was also vertical across different settings. And in this kind of assumption, usually it's thought that the justification for evidence is by observational data. And that's why historically the DSM had focused primarily on signs and symptoms, because we can all observe the same phenomenon in different possible worlds. And in this view, this is kind of the view from nowhere, where third-person observations in the way that they focus on signs and symptoms are going to get us to this kind of objective knowledge about mental disorders. So in this picture, scientist is detached. They're just basically detached from their subject, and we're basically providing this kind of God's eye point of view on the state of affairs. So, and in this kind of more general picture of science, we tend to think about experts to be primarily technical experts, people with MD or PhD degrees who have received training on psychopathology, and kind of thinking about objective knowledge in that sense, we think about as expert knowledge. But there has been, so there are kind of two ways to think about this. On the one hand, this kind of picture of science doesn't really align with what psychiatry is trying to do, because we really do not have a full, clear understanding of how the mind works, and as Paul said, or how it doesn't work when it doesn't work. So in that sense, when we think about psychiatry as a scientific enterprise, we should think about the ways in which we might want to intervene, develop interventions that might be effective in improving people's conditions. So if we want to think about psychiatry as a form of science, in other words, we have to take the goals of inquiry as our starting point in the way that other sciences do. When a lot of scientists develop models, and models are usually developed based on the kind of target phenomena that they want to study. If you want to make a kind of prediction of the weather tomorrow versus next week, a climate scientist might use different kinds of models. And I think there are reasons for us to think about psychiatric interventions and psychiatric science in similar ways. So, but that requires us kind of to revisit the notion of objectivity operative in psychiatry, and explain why and how patients could participate in knowledge generation process in scientific psychiatry. So here's kind of my summary, and I'm going to expand. So I think that we should think about objectivity in psychiatry as participatory interactive objectivity, where patients are part of the knowledge generation process for epistemic reasons, and their inclusion and interaction with other kinds of experts is necessary for objectivity. So this process is intrinsically interactive, process-driven, and value-laden. I'm not saying that we should just take patients' words for doing science. Rather, just like the way we do science, right? Like different scientists come together with different specialties and they engage in knowledge generation process, we can expand that circle to also include patients as knowers. So a lot of the kind of my, theoretical scaffolding for this work is coming from feminist philosophy of science and feminist epistemology. Another Canadian philosopher, Lorraine Coate, has been a big influence in my work because she does talk about the epistemic implications of one's social location, how knowers' gender matters on what they know and how they can kind of participate in that knowledge generation process. Similarly, we know in other biological sciences that failure to account for women's experiences have resulted with androcentric assumptions in biology and other forms of science and actually in general medicine as well, and how the inclusion of women in those scientific generation processes have been a game changer. And also, in the last couple of decades, scientists are also talking about different kinds of expertise, and there is definitely a technically qualified expertise by way of training, but also there's this new category of expertise that we can think about that is relevant in psychiatry, which we might call technically qualified by experience. So in that sense, patient reports might provide us evidence that could be overlooked in more conventional settings. So in this sense, again, this is a process where science is construed as social knowledge and patients and other experts interact. So in that sense, objectivity is not just the outcome of scientific inquiry, but objectivity is a feature of the scientific process itself. So it's not just simply the opposite of subjectivity. So here's kind of the picture that I'm developing. I'm actually writing a book on these themes about rethinking science and psychiatry. And this is the kind of picture that I want to push for. So here we have different kinds of expertise. Scientists and clinicians are technical experts, and patients are experts by experience. And there's an interaction between these three groups in the scientific knowledge generation process. So we can see these micro versions of this kind of interaction, for instance, in a clinical trial, or we can kind of see a macro version of this in the development of something like the DSM manual. But this is not a straightforward process. And this is where a lot of social factors come into play that end up kind of being epistemically important for knowledge generation. So again, the framework for this, kind of the inspiration for this is feminist philosophy of science, because one way in which we can kind of ensure that the process of generating knowledge is objective is by way of creating venues where people are able to criticize one another. So in traditional science or philosophical frameworks, we have that because a lab publishes a paper, it gets reviewed initially, and then it's out for the scientific community at large. People might criticize that and so on and so forth. So for us to imagine that patients and experts and other kinds of experts interact in knowledge generation process, we have to imagine these kind of avenues for criticism. That might mean having conferences that involve clinicians, researchers, and patients, or having journals that are designed to publish papers from different groups where things are being vetted and critically engaged with. But for this to happen, we have to recognize that there's shared intellectual authority, which might be challenging because a clinician might simply not take a patient seriously as a kind of knower because they received all that training and education. What did the patient receive? So that kind of requires a shift in the way that we are thinking about each other as like in terms of our epistemic capacities. There has to be trust between these different communities and group, respect and openness to criticism. And also, I should highlight that nobody should have automatic epistemic privilege, either on the grounds of their experience or on the grounds of their education or medical training and so on and so forth. And also, in kind of development of documents like the DSM, I can easily see this where they take one token patient in the way that, there's that one token female faculty member in a departmental committee or something, right? Where, they're not really representing a standpoint, but rather is there for kind of different political reasons. There might be kind of tendencies, desires to do that, but I really strongly encourage to not be tokenistic about this. So this kind of picture that I draw is really, really far from where we are in contemporary psychiatry. So in that sense, this is kind of going to be a philosophical dream that I want to push for. But there are some, I think, good, exciting developments in general medicine and even in psychiatry. So I'm not sure how effective and serious this is going to be, but the National Institute of Mental Health back in 2010 developed a new framework for understanding mental disorders. And this is the RDoC, Research Domain Criteria model. And the idea is, instead of focusing on mental disorders, the focus should be on the brain and our kind of cognitive capacities, and study those cognitive capacities from different perspectives, different layers. One of that layer can be brain research and brain science, but kind of one of the main lines of entry to understanding our cognitive capacities is self-reports. So that's, I think, a huge step, except that, of course, we haven't really seen a lot of publications coming about, what self-reports and how they can be used in the context of RDoC research. But when we look at other areas of science and clinical psychology and even the COVID research, there is a shift. So now, for instance, we have Patient-Centered Outcome Research Institute. And this institute actually provides funding for research that really targets directly patient outcomes, which I think would be extremely relevant in the context of psychiatry. And this process involves, in order to be able to get a grant from them, you need to involve patients in research in a meaningful way. I was a benefactor of this at University of Texas at UT Health. There is a stakeholder alliance for providing better palliative care for people with dementia and their caregivers. I was invited as a researcher to kind of participate in that conversation. But in that conversation, we also had people living with dementia, especially their caregivers, as part of that conversation and dialogue. And it was extremely rewarding to kind of see clinicians collaborating with patients and their families in that direct way to increase our understanding of how we might want to think about palliative care in dementia care. Similarly, I have colleagues in psychology department who do work on PTSD, especially focusing on post 9/11 veterans. And we are, my book is on developing this model of the self that will allow us to engage these three different groups in understanding mental disorders. And we have kind of worked, again, their focus is more clinical. There's a long wait list for veterans with PTSD and traumatic brain injury to see a clinician. So we're kind of using that group as our starting point to engage with what kinds of effective treatments that we might be able to provide by doing research and so on, collaboration. So we applied for a grant, waiting to hear. We'll see what happens. And most importantly, in perception research, there's actually a lot of interest and investment in first-person experience and subjective reports. And this kind of came to a head during COVID. So initially, smell loss in COVID was not regarded as a primary symptom or primary thing that we should be investing time and energy on, because yeah, you have smell loss, but you're not dead. That was kind of the initial attitude, because there was a lot of scarcity in providing care for people. And a patient group actually in the UK who works with, they work with Barry Smith, a philosopher and a philosopher of cognitive science, on smell loss. So this group of patients, and one of them is the lead person is a patient themselves. She has long time smell loss, and even prior to COVID, and she's always been frustrated in the medical context why her experience and all of her unstabilizing effects of smell loss, how that has not been studied. So basically, during COVID, they create a Facebook group with patients who have smell loss. And they use that Facebook group, which now has so many members, as a primary way in which where people report. But this is what's happening. I can't, I started hating my child because they smell weird to me, like very serious kind of concerns that have not really been kind of traditionally target of attention. But then they got the attention of the scientists, and that group and their experiences were involved in scientific research. And now like patients and scientists are publishing series of papers together. So I can easily see room for this kind of engagement happening in the context of psychopathology as well, if psychiatry is willing to go in that direction. So in that sense, participatory interactive objectivity fits the goals of inquiry in psychiatry. But of course, I'm a philosopher. I will have to anticipate objections. And the biggest kind of resistance that I get when I talk about this is this: I think it has definitely underlying kind of justified reasons, but also it's not scientifically validated. This idea that, well, mentally ill patients are like lack rationality. They are not good epistemic agents and good knowers, because the nature of mental disorder itself might kind of interrupt an individual's rationality. So, but first of all, there's actually no conclusive data that supports this, that we can't just equate people with a mental disorder diagnosis with them not being rational or not being good knowers and so on. So in fact, rather, we have the opposite evidence that shows that patients are capable of rational decision-making most of the time. That said, there are contexts in which they might experience limited epistemic agency in ways that I think normal or typical humans also might encounter limited epistemic agency. So, but it's wrong to, mental disorders never necessarily or universally interrupt epistemic agency. Not all conditions create impairments. And even if they do, they have varying degrees of severity and transiency. But also, again, my point is not just taking patients' words for it or just listening to the patients, but rather inviting them to the dialogue in which we produce scientific knowledge. So the kinds of biases and errors that are also feature of like scientific enterprise might be there as well, but I want to trust that the scientific process of rigor and critical engagement might evade some of those kinds of issues. So, and I want to kind of conclude by providing an example from the DSM's own history. So as many of you might know, homosexuality was once considered a mental disorder in the Diagnostic and Statistical Manual of Mental Disorders until 1973. So in this case, classifying, within typical range of human sexuality as a mental disorder was the wrong thing to do, right? DSM did not get that right. How did it fix it? It fixed it thanks to the activism of psychiatrists who themselves identified as gay. So this is one of my favorite examples. Of course, there were so many different psychiatrist gay rights activists who was behind this movement of challenging the APA to change this. But John Fryer was very significant. So his name, like he basically anonymized his name as Henry Anonymous, but we later found that his name is actually John Fryer. He was a gay psychiatrist who actually lost job and employment opportunities so many times in his life because he was gay. In 1972, at the American Psychiatric Association meeting, they made it so that because he's a psychiatrist, he was giving a talk, but he actually came to the stage with this mask on and shared his experience with, being gay and how he was deprived of professional opportunities and lost his job and how this doesn't make sense. So, and after that, as of 1973, APA removed homosexuality from the DSM, no longer identified as mental disorder. The moral of the story here is, I think it really showcases how realizing that individuals with lived experience have shared intellectual authority is an important part of it. But also, I think, trust. So I'm not sure if Dr. John Fryer would have the same kind of reception or the same kind of influence if he just identified as a gay man talking at the American Psychiatric Association meeting. I think because he was one of their own, he was also an MD, a clinician, a psychiatrist, the APA, had better time perhaps trusting their testimony and knowledge. But I think this also shows us all the other things that we have to kind of make sure in building trust, developing this kind of shared intellectual authority kind of framework in the context of psychiatric science. So in that sense, I want to reiterate that self-reports are good approximations of subjectivity. There are other ways in which we can study subjectivity through cognitive science or neuroscience, but self-reports are also good pathways to understanding subjectivity in psychiatry. And concepts like self or subjectivity are not idle or nor non-scientific. There is a way in which to create an objective form of inquiry that gets us to effective intervention methods in psychiatry if we were to follow this path. And I see philosophy of science and philosophy as a kind of good and important framework that brings us these different perspectives. So thank you. And I want to acknowledge my cats. They're my lab friends. Like microdosing, like psychedelics, you mean? So maintenance therapy is like the umbrella term, and the kind of medication that is determined is contextual. I'm not sure how like psychedelics are in the maintenance therapy, but the main kind of property of maintenance therapy is that you do that under supervision by going to a place, right? It's almost like a clinical supervised clinical injection context. So that's the kind of the term of art, yes. That's great to know. I did not know the Portugal example that decriminalized the drug, but that's an important aspect of, I think, prevention and addressing and remedy. But I need to look at. Thank you for that. Yeah, no, I mean, it's very interesting because like the concept of the self gives, I don't know, a lot of clinical psychiatry, like especially in the DSM context, is like alarming response because they think that I'm talking about Freud. And they're like, no, we don't want to do anything with Freud, but like there's so much happened since Freud, as in so much happened since, electroshock therapy and so on. So I think, another thing that's missing in contemporary psychiatric research is really engagement with cognitive science and cognitive neuroscience too. That for some reason, there's so much resistance to even thinking about the concept of the self. I know this primarily because I have some colleagues who have worked in these DSM boards and so on. Even in the context of personality disorders, there's a lot of resistance to thinking about like persons or self in understanding personality disorders. But thank you. Thanks for your questions. Should I take my own? Yeah, Sasha. Thank you. And the so yeah. Exactly. I think I have two responses to that. So one is, I think this goals of inquiry and knowing your subject matter is really, really important. So maybe in some contexts, trusting first-person reports is not going to be the best thing. I mean, even substance use disorders, like a lot of people with severe alcohol abuse disorders would deny that they have an issue, even though their partner or their kids might have a lot to say. And similarly, I think schizophrenia, the anosognosia, like lack of illness insight, might be a context. I think there are multiple paths, so we can expand the knowledge production process by maybe including like caregivers or the second person perspective. And do you know, so there's a clinician named Xavier Amador. He's a psychiatrist, and his brother actually suffers from schizophrenia, and he has the anosognosia type. So he has several books about how to engage with people even when they deny that they have an illness. So I think we need to be thinking about those kinds of things more, but it definitely depends on the context and what we are trying to study. Yes. Mm-hmm. Mm-hmm. So I have a couple of papers. You can find them Googling hyponarrativity. So this is something that I think about a lot. I think because we are reason responsive cognitive agents, we don't just respond to our biology, but any kind of representation that's out there about our experiences might grasp us for better or worse, right? In some contexts, if people, like I've written about this, if people over-identify, and we see this in college students and teenagers a lot, I am ADHD, right? Like they might have ADHD, but kind of now you're looking at everything from that one single lens, and unfortunately, that lens is crooked in that we don't have enough scientific knowledge about that lens and how it's working, right? And I think TikTok is also this kind of an interesting dimension of hyponarrativizing in some cases where, people want to be heard and they talk about their experiences, but to be listened to, perhaps, they rely on maybe these kind of scientific frameworks that they borrow from other places that may or may not be tracking their own experiences, but it kind of gets into this like loop. And this is what Ian Hacking wrote about in his earlier work, in the way in which how scientific representations might alter the way we think about ourselves and how they end up maybe even changing ourselves. That's a very, very important aspect. And I think that's definitely an impediment to trusting self-reports, just exclusively. That's why we need to triangulate it. But I think we can also think that as a resource, thinking about individuals with mental disorders who also are cognitive agents who can respond to reasons and like engage with language in these ways might provide us resources on kind of developing effective interventions for what they're experiencing. I want to say that it's particularly bad in psychiatry, but maybe it's because I think about psychiatry. When I say this in this context, so when you look at other areas of medicine, like right now, a lot of medical research engages with how to make an effective, lasting change in people's behaviors. There's a wider reception of like narrative medicine and kind of the development of like relationships with patients in a way that engages with them and so on and so forth. But on the other hand, so in that sense, they have, I guess, other areas of medicine have been more open about their limitations and attempting to remedy that. That said, we still have a lot of bias in medical research. I was just actually talking about this morning. A lot of hip replacements in senior women. Those measures are in developing those measures for those hip replacements. Men's anatomies are taken as essential. So like a lot of women over 60 and 70 who have hip replacement have a lot of discomfort because they're not fit their body. So I think there's an overall maybe not engaging with the kind of subjective or the patient group that you're engaging with, but at least from I'm the director of a medical humanities program, so I have to believe in this. I see that other areas of medicine are more receptive, whereas clinical psychiatry, when I talk to psychiatrists who are seeing patients on a one-on-one basis, they are receptive and they see the challenges of their discipline. But when you look at the scientific psychiatry, the DSM psychiatry, they're very territorial and not really engaging with some of these kinds of questions. That's a great. Uh-huh. Uh-huh. Yeah, that's a great, and it makes me also think about like the kind of emphasis on evidence-based medicine where evidence was taken primarily as randomized clinical trials, the kind of case reports or first-person reports were undermined. But that's great. Mhm. Yeah, I mean, that's the other thing, right? I think that's the similar thing is happening with RDoC's self-report category. It's more, preparing questionnaires by scientists and asking patients to say yes or no, and whether or not that is patient-centered is question. Great, thank you for the question. Yes.
Thank you for the talk. My own experience understanding both psychiatry and other subjects, for example, urban planning, there seems to be such a big difference between, say, Canada and Netherlands. The same person I know was diagnosed, treated here in Canada, moved to Netherlands, and the way they do treatment to him is completely different, and it's much more like what you said. They are the family, and they look at not just he stays out of trouble, but rather what his life should be in terms of being a good life. So that's so different. I don't understand why ESM or psychiatric cannot do the same practice.
Absolutely. I think it's all very financially driven in an interesting way. Like in Netherlands is one place actually you can get a job as a patient expert. Like they will pay you to be the expert patient. And in clinical care, you not only get a doctor and like a social worker and clinician, but you also have a patient expert who may have had similar experiences to you, and they receive additional training, and they almost act as your advocate / translator / like help you navigate that circle. And that's extremely important. But again, all of those different kinds of interventions, I mean, I think from the US perspective, that will cost a lot of money and resources. Like there's been this kind of search for that magic pill or the miracle cure, which is not really aligned with, I don't think, any area in medicine, especially in the context of mental health. Yeah. And that's why I think, that's why I think now AI and interventions are big, because that's all developed by private Silicon Valley companies. It's a very easy to make profit line, because people might think, oh, it's just a $5 app. I'm just going to download that instead of paying $75 to a clinician. But whether or not that's going to be effective is questionable. Yeah, I end up talking about money a lot. Yes, sure.
Any kind of medical related, even the patient like and you are expected people train them, tell them about the research.
That's great.
Explain, discuss with them. If you don't do this, down mark in the economy. So
Yeah.
What do you think about this? How do you think to be now
That's a great question. Like, so this COVID smell research, for instance, came from the UK for those reasons. And I'm a fellow actually at the Oxford's Collaborating Center for Values in Medicine. And that center also brings patients and other experts together in deciding what kind of values patients want to choose. And this is all in all contexts. But I think institutionalizing it is the way to go. Because when we look at historically research involving women subjects, women were not part, especially if, because they have risk of getting pregnant during a clinical trial, they were not included in medical trials in the United States up until 1992. FDA then declared you can't get funding unless you have women subjects in your clinical trial. And that was a big turning moment for women's health. I mean, there's still lots of gaps and problems, but things kind of started improving. And I think we need a similar kind of policy shift in funding distribution, because ultimately what shapes research in psychiatry is funding. And a lot of that funding historically has been traced to research that was done by experts or different. So I could have given the same talk by looking at NIMH's funding priorities over since 1960s and 70s. And there hasn't been funding for this, so there's no kind of research involvement. But I think that's a great framework. Thank you. Yes. That's a great question. So, like, first, one of the main problems in the DSM that I think aggravates potential problems is that it's so powerful. Like, you need a DSM diagnosis for pretty much anything. For clinical diagnosis, that's important for you to receive clinical treatment, for insurance, for administrative leave, medical school education. Like DSM, APA makes a lot of money because the DSM is sold to medical students or health professional schools. So, then the APA says all of these goals of different, or all of these different uses of DSM are compatible, but I fully disagree. They are not compatible. What we want for research might be different from what we want in intervention. So as much as I want the DSM to go away or to like lessen its power, I mean, I think in so many ways, it is actually a really good diagnostic framework. I mean, it's amazing how accurate and representative some illness descriptions, but it's also missing a lot of things that are important in the clinic. And because it's doing that, it's not as effective as a clinical tool as it's being deemed. So I think we might want, I really want to push for a more pluralistic framework in thinking about mental disorders, but I don't know, again, with the existing funding structures, insurance, healthcare system, and so on, I don't know how feasible that is. I mean, increasingly, so this is a great fun fact. So in 1952, when the DSM-1 was created, it was a joint production of US military and psychiatrists and clinicians because it was right before the Korean War. And we needed a document, a way of weaning out who goes to the war and who stays back. And starting with the DSM-2, military was left out of the picture. It's become a primarily psychiatric dominant thing. But now, Veterans Affairs and the Department of Defense, they have a lot of funding and they have a lot of interest in clinical treatments, especially post 9/11 veterans and the prevalence of PTSD and TBI. They don't use the DSM anymore. I mean, they use it to collect data sometimes, but they're primarily using the ICD criteria, which is very interesting and telling to me, like once behind the development of this framework, even they don't trust this manual anymore. Yes. Exactly. Yes, yeah. No, absolutely. And I think that actually shows, like in my case, shows how this worry that turning to subjective will, spoil our scientific goals is not realistic, because actually you can do even more science if you turn to subjective. And those are really, really good examples. Like I think default mode network and all the connected, like, the mindfulness, like they're all very, very interesting and should be supported and funded. I mean, so I talk primarily about self-report as a way of getting to subjectivity, but we can also get to subjectivity by using different kinds of scientific approaches. Absolutely true. Learning, yeah. I mean, even learning is so understudied or understood, because you can, learning to cope with certain things involves learning and developing new habits and, so on and so forth. So we need that kind of research as well. Yes. Great question. We can write, another book on that. I mean, that's exactly like that's the worry, right? I think the range of normal or typical for the DSM is really, really like narrow, and it does not encompass and recognize the intrinsic diversity and complexity of human beings. So it's like very individualistic, for instance, in the sense that mental disorders are framed as things that happen to you and it's your problem, not things that might emerge due to like negative social environment and so on and so forth. And therefore the solution is also in you. I love Joe Heinrich's work on weird people. So he's an anthropologist. Weird stands for Western educated, industrialized, rich, developed cultures. And he says that most of psychological and sociological research about human mind is grounded on these like weird studies that are conducted, at on the East Coast at the campuses of like Yale and Harvard, like with not a very representative group of individuals. I think that's a huge element. That's why it's hard for me to talk about mental disorders per se, because in speaking that way, I am almost like reifying things, but that's why I want to kind of bring the conversation back to the self, because then we can embrace that complexity and diversity, and maybe Western psychiatry might frame something as a mental disorder, but it would not be a problem in like Middle Eastern culture or something like that. But great question. Thank you.
Now we have lunch break, and go ahead and check. I'm pretty sure we start again at 1:30. Yeah.